Wednesday, November 22nd. We'll start with the land acknowledgement. Ottawa is built on unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them in this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors First Nations, Inuit, and Métis people and their valuable past, present, and future contributions. The title of today's presentation, well, I'll read it off the slide because it may have changed a little bit. Moving healthcare upstream to address social needs, exploring the use of social prescribing at local, national, and global levels. Today's presentation is in recognition of National Child Day. And I'll introduce Dr. Bennett, and then she'll introduce her co-presenters. So Dr. Sue Bennett is well known to many of you and is a full professor in pediatrics at the University of Ottawa, director of social pediatrics at CHEO, and medical director of the Vanier Social Pediatric Hub in Ottawa. She was formerly the director of the Child and Youth Protection Program at CHEO for over 2 decades. Sue is the co-principal investigator of the Public Health Agency of Canada's Mental Health Promotion Grant to develop, implement, and evaluate the first social prescribing program for children and youth in Canada. Sue, please take it away and introduce your co-presenters.
Okay, Dave, thank you. So good morning in Ottawa, and I have to say good afternoon in UK London. Bonjour, and thank you and merci for your kind introduction, Dr. McNally. Every year I host a grand rounds to celebrate National Children's Day and the United Nations Convention on the Rights of the Child, adopted by the UN General Assembly in 1989. It's an aspirational and human rights treaty that recognizes that all children everywhere and always have the right to health, the right to education, the right to be protected, and the right to have a voice in all matters affecting them. Today, we have a very special lecture titled, as you can see, Moving Healthcare Upstream to Address Social Needs, Exploring the Use of Social Prescribing at Local, National, and Global Levels. And I feel so privileged to be presenting with the 2 eagles today in the social prescribing movement. And I see that Caitlin is there, which is great as well. So I'll introduce Dr. Bogdan first. Dr. Bogdan Chiva is a British physician currently working as the clinical lead and global director of the National Academy for Social Prescribing, which was founded in 2019 by the Secretary of State for Health and Social Care. Bogdan has played a key role in the development of social prescribing in England since 2015 through establishing and chairing the National Health Service England Social Prescribing Champion Scheme, consisting of over 20,000 doctors, medical and healthcare trainees, championing the subject in their own institution. His work has influenced national and international healthcare policy and has been instrumental to spreading and scaling social prescribing globally by hosting delegations and ministerial visits from over 30 countries, as well as implementing social prescribing in the core curricula of the majority of universities and medical schools within the UK. As an honorary lecturer, Bogdan currently lectures at University College London. In addition, he holds teaching roles at Imperial College London, Harvard Global Health Institute, and has recently been named top 100 most influential people in health in the UK. Caitlin, welcome, is a PhD candidate in health quality at Queen's University, the social prescribing advisor at the Vanier Social Pediatric Hub, a research assistant at the University of Toronto for a study on co-production and social prescribing, and is the co-founder and co-lead of the Canadian Social Prescribing Student Collective. I'll just in the couple of slides next, please, Caitlin. The disclosures, the social prescribing program at the Vanier Social Pediatric Hub has received financial support from PHAC, Health Promotion Innovation Fund. Otherwise, the presenters have no conflicts of interest to declare. And next slide, please, Caitlin. The objectives today, we're going to learn what social prescribing is and what it looks like in practice, understand the importance of social prescribing for children and youth, and explore the current state of social prescribing locally, nationally, and globally. And over to the 2 eagles.
Wonderful. Thank you ever so much for such a wonderful introduction. It's very humbling. I wasn't sure you read the whole biography, so it's a slightly humbling moment, but really grateful to be here with all of you. And I wish you were with us in sunny England. Well, in fact, it's raining as per usual, so you're not missing much. I'm sure we share the same climate, but it's a great pleasure and a great joy to be here with you, and a true honor. So hopefully we have a chance to discuss the subject in deeper detail as well. But first, we're going to start with a project that Caitlin has led for us across the globe, which is the International Definition for Social Prescribing. And I will then take it from there to introduce the concept and break it down and see what this means for the healthcare system, not only within the UK, but also healthcare systems across the globe, and how these common challenges that we're facing are uniting us to find new models and new innovative pathways in health. Caitlin, I'll let you say a few words about the definition first, and I will then move from there.
Absolutely. Hi, everyone. So happy to be here. And I am running in between different things here today. Bogdan and I were just lecturing at UCL, so I apologize. I'm in a train station right now. It's very loud. And after this bit, I will run to where Bogdan is at the South Bank Center. So I'm really excited to talk to you about this global definition. This was a piece of work that was the result of 48 social prescribing experts across the globe coming together, 26 different countries represented, to try and agree on what social prescribing is. And this is the end result. They've said that social prescribing is a means for trusted individuals in clinical and community settings to identify that a person has non-medical health-related social needs, and to subsequently connect them to non-clinical supports and services within the community by co-producing a social prescription, a non-medical prescription, to improve health and well-being and to strengthen community connections. So some really key pieces there. These trusted people, in many cases, it's a physician. It may be some sort of other healthcare provider. It's often based in healthcare, not always. There's this identifying step, and that might be with a validated screening tool. It might be informally. It's looking for social needs. That's what it comes down to. And it's about connecting that person, not just signposting, not just giving them a piece of paper and saying you should go do this, but actually doing the hand holding, connecting them to that community asset. And this happens through co-production. It's with the person. It's not to the person. And you'll see that later when Dr. Bennett talks about what we're doing at the hub. And this is all about health and well-being, improving health and well-being, and really focusing on our community and strengthening those connections within the community. So that is what the global definition looks like in terms of what social prescribing is. Back over to you, Bogdan.
Thank you very much, Caitlin, and well done for this piece of work, which was the missing puzzle, and missing piece of the puzzle. And we'll come back to this definition because it's very important, and we can discuss further about this. But if a picture is worth 1,000 words, I'm sure a video is worth 1 million words. So bear with me as I try to share a video of what social prescribing is, and you'll have to bear with me because I'm going to have to share my sound as well. So hopefully this works, and I'm going to look for thumbs up as soon as you start seeing it. Give me 1 second just to briefly work this out. Very easy. Let's see. Can I just get a thumbs up if you will hear the sound? Let's see. 1 second.
Look, we all want to be healthy and happy. That's not an impossible idea, a lie, or a dream. And it may seem like quite an obvious thing to say, whilst we sit wondering whether society would allow us to say we were any other way. You know, that pressure of appearance. Are we allowed to say when we're not okay? Because all too often, physical or mental health difficulties get in the way. Whether it's events beyond our control, personal circumstances, or genetics at play. Because if 1 in 5 GP appointments are for non-medical problems, then this could be a time to explore other possibilities and options. Like social prescription, a system that takes a different approach, where they won't just deal with the symptom, but sit with you to trace it, understand the cause, and then create a plan to replace it. Talking about your health, finances, housing, or stress, before linking you to activities that empower and suit you best. What if you were prescribed a social engagement, a social arrangement, to get a pep in your step and your feet on the pavement, a brush in your hand, a tune from your lungs, a talk and support to help you manage your funds. I'm talking about a place to feel connected with the community you've selected, making your activities more effective, experiencing as a collective so you are positively affected whilst feeling safe and protected. Surrounded by new people, allowing you to feel part of something bigger than you. We all want to be healthy and happy. And it's not just a nice idea, but a system that works, that asks if medicine isn't the only option and puts you first. With a wide range of solutions to help you get through, a social prescription could help you too.
Okay, and now let me just pause the video from my end because I'm still hearing it. 1 second. Wonderful. So now the heavy tech side of the presentation has gone out of the way. We can now move on into the rest of the presentation. And bear with me, multitasking in here as well. Wonderful. Brilliant. So I'm going to zoom out now for a bit because, as many of you, I am a clinician by background. I'm an emergency medicine doctor, and I'm going to zoom out just to showcase some of the statistics that have been coming in from England, which I'm sure will be no different from what you see in Canada, and also what colleagues across the world are seeing in different healthcare systems at the moment. And what we're seeing is an increasing aging demographic. We are certainly seeing a rise of the impact of the social determinants of health on our health and their impact. And in England alone, 1 in 5 of our doctor appointments, based on research, approximately 20% of all the appointments and every single person presenting to the doctor is based on pure social reasons. So if somebody turns up to the doctor, 20% of them come for pure social reasons. And these are usually related to loneliness, isolation. It might have to do with their financial worries, debt and housing. And we are not considering psychological reasons as part of this 20% either. And so that's very concerning. More than this, 25% of the patients that I see in the emergency department in England actually come for medication side effects. So 25% of the people I see come for reasons for medication that we prescribe wrongly at times as well. 6 out of 10 people have at least one chronic condition in England, and more so what we've seen recently, which is shocking and with interest to pediatrics. One in three, one third of our teenage girls in England are actively self-harming at the moment. So not contemplating, not thinking about it, but 1/3 of the teenage girls in England are currently self-harming due to severe mental health crisis that we have at the moment. And so all of these problems and all of these issues have put a huge pressure on our healthcare system, both in England, but also around the world. And in 2019, the government tried to find new policies and work on innovative models to shift the way that the healthcare from hospitals to communities and to home environments, so that we try to prevent and create health at home rather than consider the sick care delivery of health that we've been living in as a model for a long, long time. And this idea was implemented in the NHS long-term plan. This is a roadmap of the healthcare system that was published in 2019. And there's a few keywords in the first chapter of that document and that will stand out for you immediately on the slide as I've mapped out, which are boosting out-of-hospital care, very importantly, redesigning and reducing the pressure on emergency hospital services, using personalized care, shared decision-making, personalized budgets, and making sure that individuals are able to co-create and co-design the care pathway together, and a deeper focus on population health and digitally enabled services at the core. And there was this idea of a social prescribing policy model. Social prescribing has been something that's been with us for probably more than 40 years. However, there were no official investments in it as a policy model. However, in 2019, together with the government, we launched a pilot for social prescribing link workers, and there was a commitment of 1,000 social prescribing link workers to be recruited nationally at the time. And the idea behind it was exactly what Caitlin described, which goes away a bit from the idea of signposting, as you'll see in this picture. This is a toolkit we designed with the World Health Organization. And as you will see in this picture, let's consider a patient, and you will see an elderly individual here. It doesn't have to be, however, it's just for the purposes of an example. It could be a child, it could be a young adult. It doesn't have to be an elderly person. But consider this lady, let's call her Sarah. Sarah comes to the doctor with, let's say, low mood or a headache. What would happen in this case is that the doctor does their biomedical tests, they look after the biomedical elements, and they realize that there might be another aspect or other elements that influence Sarah's health. And in this case, they would refer Sarah to what we call a social prescribing link worker. The social prescribing link worker is a new job that was created and designed in the UK. It's like a nurse, like a physiotherapist, like an occupational therapist. It's simply a new role that we introduced to help us with the psychological and social factors that we as clinicians may not have time to deal with during our busy practices. I'm not sure how much time clinicians have in Canada, but we in the UK have approximately 10 minutes with each patient. And in 10 minutes, sadly, what would normally happen with a patient is we have time to prescribe another pill if they come in with low mood, maybe an antidepressant, and we send them back home and we ask them to see us again in 2 weeks' time. So we shoot ourselves in the foot because we are sending them back home to what made them sick in the first place, rather than asking them what is it that truly matters to them and getting to the deep root of the cause of their concern. And we would normally do that as good clinicians, but with today's pressures on the national healthcare system, we don't have the time to do so. And so the link workers, this new role that was designed and introduced in the UK policy, gives people the most valuable resource of today's day and age, something that I wish I had with my patients more of, which is time. They have 1 hour with each patient, and in that 1 hour, they are able to sit down, use healthcare coaching and motivational interviewing to understand and dig deep at the root cause of what's brought them in. In Sarah's case, for example, it might be that her husband passed away maybe 6 to 8 months ago. She has no relatives, no friends. She's living on her own. She might say that the only people she visits is ourselves as the doctors, so she feels looked after. But actually, there's no one else there to support her other than that. And so instead of prescribing another pill, the link worker is able to refer Sarah, after they've understood the problems, refer them to the local community for an activity or a class where they could meet other people and get involved in various activities. This doesn't just have to be for loneliness or isolation. In fact, in the UK, in England specifically, because of the austerity that we live with currently, because of the change in government and the policies, we are actually seeing a lot of referrals for housing and financial support. So you may ask, well, isn't that what the social worker does? Well, yes and no, because the social worker would only support those who have access to those services. And what the link worker does is it becomes this voice, this independent voice for the patient. It advocates for them, and especially when there's a language barrier for people who may not be able to speak or write on the benefits forms, the link worker is able to accompany the patient to apply for those benefits, and increases their chances of getting a house. They're not promising the house. Social prescribing is certainly not solving the housing crisis, but they're increasing their chances of knowing what's available to them. So it's a whole spectrum. It works for people who are very well off and very educated, who may need a lighter approach, but it also works for individuals who are coming from the poorest boroughs and who may be most impacted by social determinants of health. In fact, we at the National Academy of Social Prescribing believe that social prescribing works best for those who are most affected by social determinants of health. And that's because those are the individuals who would come to me in hospital when they've hit rock bottom. They are the individuals that do not want to actually seek our help. They only come to me because their pain has got so bad, because they need us. And if I'm a good clinician, I've been trained on social prescribing, I will know that there's something more happening in their life, and I'll be able to then connect them to a link worker who then can spend time with them to connect them to the other services in the local community, rather than me failing them as a clinician because of the lack of time that I have available in there. And the final step is this community element in here. which is the social prescribing link worker has a menu. Imagine going to a restaurant and you have a menu of different food items. Is the same in social prescribing. They have a menu of all the activities that are happening locally in the local area and local community, and they're able to refer the individual there. So just wanted to point out exactly what Caitlin said. It's not the clinician telling someone to go do some gardening or telling them to go exercise. That is simple signposting. It's what you and I as clinicians have probably done for a long time, but we know telling people doesn't work unless we engage with them. So the magic really happens in here, where there's that co-design and co-creation together with the social prescribing link worker. And I'm conscious of time, so I'll just move on very briefly. And I'm just going to try and clear out my notes. Apologies. I think I can't erase the previous content for some reason, but just how this is funded as a national pot in England for us, and the training is done locally. Although the money comes from the government for the social prescribing link worker, the training is being done at the local level, and we are able to then tap into the local demographic. Anyone can become a link worker as long as they have the numeracy and literacy skills, as well as the IT skills necessary. And that is important because it means there's people from the local voluntary sector who are able to get involved in this work, and who are able to tap into the local demographic even further. The other element to say is that who can refer is absolutely anyone and everyone. There's self-referral pathway in there as well. People can self-refer themselves as well. And also just to mention that you as a secondary care clinician can refer people to social prescribing, but also the nurses, the physiotherapists and the receptionists themselves can refer as well into the system as well. Does it work? Well, this is a study from the London School of Economics that we've had recently, and it was a social return of investment study, and it showed that every single year social prescribing saves the healthcare system in England 4.5 million less GP appointments, so primary care appointments that don't have to take place because of social prescribing. And that translates into roughly £300 million of return of investment. The program for the link workers costed £225 million nationally. So you're not only getting your money back, but you're also left with 80 million pounds to reinvest back into prevention and other models out there as well. That was just for primary care. However, in terms of emergency department, there's several PubMed studies that you can find online, but there's several examples from England where in places where social prescribing has implemented, there's been significant reduction in A&E attendances and re-attendances from people who've been referred to social prescribing. And the studies that are out there quote between 20 and 40% decrease in A&E attendances with areas that use social prescribing. For those of you who want to read more about the evidence, we have developed a 10-university collaboration, an academic collaborative in the UK with University of Oxford, University College London, and several other partners. And we've done a series of rapid evidence reviews to date, which you'll be able to find following this link. And there's one topic, there's one area around children and young people, there's one around physical activity, the economic impact, and so on and so forth, if you wanted to delve deeper into the current evidence model as well. And I'm now just shifting gears as I'm reaching the end of the presentation to the international stage. And it's really exciting to have Canada involved. We have around 32 countries around the globe who are currently developing social prescribing. Many of you will realize and will notice that there's nothing new in the social prescribing model. In fact, it's similar to what I would call, it's similar to good old wine. It's always happened in the past. It's just a new bottle. It's old wine in a new bottle, in new branding, but good communities have always done social prescribing. I think what's different is that link workers and social prescribers provide the glue between healthcare and community and offer this extra layer of development in terms of social prescribing. And they have different names around the world. Japan has a fascinating model with Sheikatsushian, they call them. And instead of them being based in healthcare, which is the model from the UK, they are based in the community. However, they don't interact as much with healthcare. So for us in England, it was crucial that the social prescribing link worker lived in healthcare so that we can catch those individuals from poor to poorest boroughs who'd be most affected by social determinants of health, who would present to the hospital for medical reasons, although they would have other issues beyond those as well. And if you want to read more about the different case studies around the world, if you'd like to have a glimpse at the other countries and what they're doing, we've worked with the World Health Organization to publish a global report, including case studies from 25 different countries around the world. And you'll be able to download this for free following the link. And I'll just put it in the chat at the end of my presentation as well. And so I'll just end there because I know that there will be questions at the end too, but I'll just leave you with a final thought. The sick care model that we've developed over the years has sadly made us think of health in terms of doctors, nurses, pills and procedures, and the model where the doctor knows best and the white coat with pens lined up here telling people what to do has dominated. However, I think we've confused the idea of health with healthcare and the institutionalized way of delivering health. And so what I want to leave you with is just some food for thought, but just to say that the national healthcare system that we have in England looks a bit like this. Hospitals really are for repairs. Health really happens at home and is made in our local communities. And that is the secret behind social prescribing. It tries to become the glue between healthcare and local communities and trying to tap into the assets that we have on the ground and to strengthen our local communities. I hope that was useful, and I will now move on to the next part, which is social prescribing in Canada.
Thank you so much. So I'm going to give you a very brief overview of what the landscape looks like in Canada right now. Next slide, please. So like Bogdan said, this has really been happening for so long, right? But people have just been kind of doing this without labeling it and informally, not with structure. And so the first official kind of social prescribing pilot that happened in Canada was done by the Alliance for Healthier Communities between 2018 and 2020. And in this pilot, over 1,100 clients from 11 community health centers across the province of Ontario received a total of nearly 3,300 social prescriptions. So it was quite a large pilot. Next slide, please. And the results were incredibly promising, hence the kind of momentum and the interest that it kind of ignited across the country. The findings showed that clients reported improvements in their mental health, decreased loneliness, and an increase in social activities. You can see the stats below there. I provided them. And they also spoke to the healthcare providers, and they reported that social prescribing is useful for improving client well-being. But not only that, it actually had an impact on healthcare demand. So there was a reduction in repeat visits, which is pretty exciting. And so this actually won the Best International Social Prescribing Project Award in the UK. They have the Social Prescribing International Conference. And from there, there's just been this explosion of interest in social prescribing across Canada. Next slide, please. And now, unfortunately, I'd be here for hours if I talk to you about all of the different programs that are happening, but I'll give you a little bit of a snapshot. So out in BC, if you can just hit next slide, please. We have PARX. So this is Canada's first national evidence-based nature prescription program. This began out in BC, but it's now available across the province, which is really exciting. So providers can give out passes to their patients for national parks. Next slide, please. We also have United Way BC. So they're delivering a social prescribing program through 19 community agencies across the province, specifically for older adults. Next slide, please. We also have Healthy Aging Alberta. So they've launched a program for older adults in 3 communities, and they're currently expanding out to 7. Also focused on older adults, though, and the same for the Alliance for Healthier Communities in Ontario. They have the Links to Wellbeing social prescribing program for socially isolated older adults. We also have programs focused on specific aspects of our health. So there's a social prescribing program for better mental health focused on adults in Ontario in 28 locations. Next, please. There's a lot happening, clearly. We also have a Black-focused social prescribing project that is happening in 4 different community health centers across the province. One of them is in Ottawa. And the last one we have is interesting. We have some government interest now as well in social prescribing. And so the Health Accord for Newfoundland and Labrador has actually called out social prescribing, said this is really important, highlighted the importance of it, and said that they will pilot this in one of their health regions. So there's a lot of great work happening, but what I'll say is, if you notice, looking at what's out there right now, there's not a lot happening for children and youth. And, you know, if I were to argue where you get the biggest bang for your buck with social prescribing, it's let's start young and focus on, you know, addressing health and well-being and health inequities at that stage of life when you have the greatest impact across the life course. So that's why we're talking to you today, just to let you know there's not a lot happening, and it's a great opportunity, I think, to really look at this gap and think about how we might be able to change that and start to have a lot more happening with this population. Next slide, please. So what's really exciting is we actually have a national hub for social prescribing now. The Canadian Institute for Social Prescribing was launched in 2022. And this is our national hub to really kind of build this momentum, be this convener, and make this grow just like it has in the UK. And so you can find their information there. I won't speak too much more about that, but really exciting because there's really not that many countries out there that have something like this beyond England and Canada. Next slide, please. We also have a student collective, which is really exciting. So we launched also in 2022, and we now have 250 students across the country who are passionate about this and want to support this and help this grow. And so that's a really exciting thing to see the student movement growing. And yeah, that's kind of a very quick snapshot of what is happening in the country. Now, why is it important? I'm going to talk about this generally, and then Dr. Bennett will get into the importance of this specifically for children and youth. So next slide, please. So I'll read this to you and then kind of talk a little bit more about it. So medical care is estimated to account for only 10 to 20% of the modifiable contributors to healthy outcomes for a population. And we know that the other 80 to 90% are sometimes broadly called the social determinants of health. I'm sure this is not new information to you, but it's super important and very relevant to social prescribing. So next slide, please. I'm going to now show you this diagram that I really love, comes from the National Academies of Sciences, Engineering, and Medicine in the US. And, when we think about where healthcare happens right now, what does it look like? It's really very downstream, right? If you think about, probably heard about this kind of public health sort of story of, people falling into the water and, healthcare is essentially catching people at the bottom of the stream, trying to stop them from drowning. So, healthcare is very downstream. We have clinical care at the bottom here, all the medical interventions that we provide, very downstream kind of stuff, not actually looking up the river and thinking, why are people falling into the water here? Not considering that. And so next slide, please. Essentially, social prescribing is considering, okay, what about those social determinants of health that are happening at that community level, right? Let's look upstream. And so I'm sure, you know very well, we have this kind of, community level stuff happening where, if we want to impact the social determinants, we have to improve the community conditions. We change laws, we change policies, we change different regulations, we create healthy communities. And then there's, the provider left in the clinic wondering, well, what exactly can I do, right? Like, how can I make an impact on this? And so essentially what option you have is, these downstream manifestations of what happens at the community level. Those are social needs. Next slide, please. So we have this middle stream, and that's where social prescribing can really happen, is this, at the individual level, addressing these social needs and trying to improve health and well-being by addressing those factors. What I'm even hearing now, to be honest, is that social prescribing can not only impact at the midstream, but it can actually also have community impacts. And we can also be making an impact at that more upstream level. So really exciting. I think this is a good way to kind of conceptualize how does social prescribing fit into healthcare. It's about moving upstream, really considering why are people falling into the river. Next slide, please. So, why is it important as well? Well, the quintuple aim, you might be familiar with this. This is kind of like our guiding star. How are we going to achieve high quality health systems, not only in Canada, but across the globe? And we definitely need more evidence around social prescribing, but the evidence that is out there is actually really promising. And it shows that social prescribing can impact on all 5 aspects of the quintuple aim. I think that's pretty remarkable. There's evidence to show it improves patient experience. It also improves provider experience. It brings joy in work to actually know that you are really addressing the root causes and the true factors that are impacting your patient's health and well-being. There's also some research around the economic impact, so reduction in healthcare demand and cost. It's also seen to be an intervention to advance health equity, and that's a really key aspect of what the Canadian Institute is doing right now in Canada. And then in terms of population health, lots of evidence to show that it can improve health and well-being, which is really exciting. So it can impact on all 5 aspects of these things that we need to be focusing on to achieve high quality healthcare. So I think that's definitely an argument why this is so important and should be on our radar. And last slide, I will just leave you with this little anecdote that I really like to share from a physician here in the UK. And she says, in the 30 years I've spent as a family doctor, social prescribing represents the most effective, wide-reaching, and life-changing of all initiatives to date. And I think that speaks volumes to, you know, how people are seeing this change lives on the ground, and how it really is just so important to truly impacting health and well-being by looking at all those factors that impact our health and well-being much more than, you know, the 4 walls of hospital. So that is all for me, and I will pass it over to Dr. Bennett now.
Thanks, MSc, Caitlin and Bogdan. And now, why social prescribing is important for children and youth. And children have a right to express their views in all matters affecting them and to be given due weight. Social prescribing empowers children as rights holders, as active participants in their own health care. And we ask them, what matters to you? Not in the traditional model, what's the matter with you? So we ask, what are your dreams, hopes, wishes, and goals? And we work together for them to achieve them. And we have a new science of child development and know that the social and environmental influences impact brain structure and function, as well as the genome through epigenetic mechanisms. We also know from the adverse childhood experience, ACE studies, that childhood stresses like family dysfunction and living in poverty can impact mental and physical health over the full lifespan and into next generations. Social prescribing provides positive childhood experiences that can mitigate the influences of negative environmental influences and in themselves can promote the full potential and development of the child. The World Health Organization stated last year that populations most disadvantaged by social determinants of health are most likely to benefit from social prescribing. So social prescribing is also a tool to increase health equity. Next slide, please. So we look at the literature, and really we only have 2 papers, both from UK recently, for social prescribing and children and youth. One is for children 16 and young people to 25 years, and the other 11 to 24 years. And the results showed positive impacts in health and well-being, particularly in mental health, decreased loneliness and isolation, decreased visits to emergency rooms and primary health care. And for every £1 invested, I don't know what the exchange rate is at this time, Bogdan, but there's an annual return of £5. And research shows there are 2 main mechanisms that underpin these results. Social connectedness and a sense of belonging can reduce feelings of depression and anxiety. And behavioral activation involves regularly engaging in activities that are positively reinforcing, which can improve independent skills and self-esteem. Next, please. Social prescribing, next please, at the Vanier Social Pediatric Hub. This was created 6 years ago as a partnership between CHEO and the Vanier Community Service Centre. And the Vanier Social Pediatric Hub enables access to comprehensive integrated health and social services to children and youth and families living in disadvantaged circumstances. The referral is for children 0 to 17 years of age who live in Vanier or go to school in Vanier, and who have complex psychosocial needs. We have an integrated interdisciplinary team with social workers, lawyers, and a multiplicity of other services with a kitchen table comfortable model where everyone sits around the table, drinks tea, and we have snacks. And we say, how can we come together to assess the issue and come together with a joint action plan? And the child and youth is the center of the process. Next, please. This is a map of Ottawa with Vanier neighborhood in a red circle on all demographic indicators, and we have socioeconomic index here. Vanier is one of the most vulnerable and underserved neighborhoods in Ottawa. Next, please. So in 2022, we received almost $500,000 from the Public Health Agency of Canada Mental Health Promotion Innovation Fund to develop, implement and evaluate Canada's first social prescribing program for children and youth. And social pediatrics is closely aligned with social prescribing. And indeed, since our hub's inception 6 years ago, we've been prescribing, although we weren't using that language, food with home visits by our incredible medical students and check-in for health and social needs. That's the More Than Just Soup initiative. We've been prescribing music activities through Orchestra's social development program and prescribing museum visits, as well as the usual social support interventions for income, employment, housing, transportation, and immigration issues. Much scholarly activity has resulted. More Than Just Soup students, medical students published in academic medicine, and will be presenting their work at the upcoming Child Healthcare Canada conference in BC. Our pediatric residents have presented their museum social prescribing work at international and national conferences. Next, please. So we started by the SP program by asking our local children what activities they would like to have in their community. And here we have a word cloud representing 200 responses from local children. Significantly, we conducted this survey last November at the time of the World Cups in Qatar. So not surprisingly, soccer was the most prime requested activity. Next, please. So how does social prescribing work at the Vanier Social Pediatric Hub? You can just move along and along. Okay, so the hub team identifies that, could we just go back, sorry, identifies that the child and youth has non-medical health related social needs, and a referral is made to our connector, our link worker, who is a social worker, who then meets with the child for up to a 1-hour appointment. And they both come together for a co-production of a social prescription, non-medical prescription. And then the connector social worker connects the child and youth to non-clinical supports and services within the community. Okay, next, please. The act of writing a prescription, which is given to the child, is a concrete demonstration of taking the child's wishes, dreams, and goals seriously. It gives credibility to a social intervention. Next, please. And we can go to the next one, actually. Here are lots of happy kids excited to start their chosen activities. Next, please. And here we have the 3 houses tool. And our team had virtual training from researchers at Great Ormond Street Children's Hospital, London, England, to provide standardized tools for interviewing children 4 to 17 years of age. So the 3 houses tool we find very helpful. House of Worries, House of Good Things, and House of Dreams guides us through the conversation with the child. For example, this child, if you look at the middle house, the child likes going to play in the park with water and likes the water toys, likes to hug their sister. On the left, the House of Worries, the child does not like limits set on Nintendo and does not like bugs or baths. Their dream was to go to Japan on the right, as well as to do gymnastics. So a prescription was made for a 6-week gymnastic program. Next, please. So here are kids enjoying their socially prescribed activities: mini medical school, arts activities, visiting museums. Of note, Dr. Nicole Racine and her early lab trainees and I obtained a CHEO grant to study the impact of a socially prescribed forest camp experience in collaboration with the Canadian Museum of Nature this summer. Dreams Take Flight took 4 of our kids to Disney Orlando for a day last week. Next, please. So we address any barriers that the child is facing. We can just go through the list. We conduct social prescribing sessions in locations that work for them, offer to accompany to social prescribing activities. We strengthen existing community partnerships and develop new ones to offer free or low-cost prescriptions. We cover the cost of social prescriptions that are not free, and cover cost of transportation to social prescribing sessions and activities. And we have had an amazing response from our community to partner with us and provide free activities for our hub kids. And you can see just some of the logos of those organizations here. For example, the 7 federal museums have given us free family passes, and the NAC free tickets to any of their events for children, youth, and families. And it really takes a village. And I don't want to forget the incredible partnership that we have as academic pediatricians and healthcare professionals who care about research and assessment and evaluations, let's not forget our Faculty of Medicine partnership and the Faculty Social Accountability Office. And I want to recognize our wonderful volunteer and community service learning medical students and our pediatric residents for all their service to our hub families. A big appreciation. Thank you, MAC. And on the last slide, Dr. Bogdan organized a meeting of the Global Alliance of Social Prescribing earlier in the year at the National Social Prescribing Offices in London, UK. And here, Caitlin and I are at the meeting with the co-founders of the UK Social Prescribing Network, researcher Murray Polly, and Dr. Michael Dixon, who is also King Charles's personal physician. You are most fortunate, Bogdan, to have support for your work at the highest level, and we in Canada are at a much earlier stage of advocacy for funding. We are looking forward, however, to future collaborations with you and your colleagues in the UK for specifically a multi-site study on the impact of social prescribing on a children's hospital mental health waitlist. We'll keep fingers and toes crossed for that one. So I'm going to say let's open up for questions and discussion.
That's great. I would say that was super interesting. I was really glad I attended Grand Rounds today. Well done. Do we have any questions from our large audience? Maybe I'll kick things off while people are thinking, figuring out how exactly to word their question. But Sue, the question I have for locally, I mean, what you're describing makes it, and your co-presenters are describing make a ton of sense. So locally, you're getting a lot of buy-in from companies and organizations. What sort of help would you want from individuals? Like, in what ways could individuals assist with what you're doing?
Good question, because we're always working with non-profit community agencies with low resources. That means low human resources and funding. And what was a surprise to me, because I know in England, the independent funding is for link workers. And I had this ideal that within our Vanier Social Pediatric Hub, we could use our social workers to be the link workers and to follow through with the activities in the community, because it's not just the activities that we are seeing the impact on the children's mental health, but it's the relationship of the link worker that follows through and develops a trust-building relationship with the child. But for us, we have 100 kids on our caseload with actually very limited resources already. And for our social workers to go online and look with the child's dreams in all the websites and update to see if those websites are updated, to coordinate that with the agencies and then with the families who are already high stress, the highest stresses, toxic stresses going on that we're covering in our communities. They're spending an awful lot of time on that piece of the link worker. So we really need individuals, and as we've seen from Bogdan, it can be volunteers. The link workers can be trained up and have any kind of background to build trusting relationships and to take those our kids into the community. So I think we need link workers clearly to be added to our community programs. Bogdan, you might have something to say from your long experience.
Yeah, I mean, just to chip in, just to say that there was a big debate around the creation of a completely new role in the workforce. Why would we create link workers as a new profession when we could use, existing workforce like social workers or others? for us, it was a no-brainer because our healthcare system in the UK, I wish I could tell you it's amazing, but actually we're on our knees in terms of waiting times and waiting lists. We really do not have staff. And actually for social workers, they are overwhelmed themselves. And so we had to find a new workforce. And the link worker was that one person that came in with fresh eyes and stood one leg in the community and one leg in healthcare. We really love this idea of them being able to access the files, the medical files being based in healthcare, but actually being able to be the glue in the community. And the people who apply for the job are, as you say, Sue, volunteers. They would have done this job in the community, regardless of social prescribing or not. So this really provided the structure and framework. And there was a big debate nationally at the government level of whether these individuals should have a qualification at university level. And we all disagreed because there were so many people with local intel and the local community who were doing this work for 10, 20 years now. They don't have an MBA or a degree, but they have the leadership skills of an MBA, graduate based on lived experience. So I definitely echo the idea of a link worker. And I think starting with a pilot is the best place to start. We started with pilots from 2015, 2016, and the government saw the return on investment and they pushed the funding throughout after a few small pilots.
Great, thank you for the answer. I think Toby, your hand was up next. Do you want to go ahead?
Thanks, Sue and colleagues for this amazing work and truly tremendous. I think my question is just, and Bogdan somewhat answered it, but how do you see us making this accessible to other sites? I'm sure there's lots of people on the call other than me that see this and would love to make this available to our patients. So how do we, what's the next step that you see in terms of rolling this out more broadly? And then I think also, I think you alluded to, the sustainability piece of both accessibility more broadly, but sustainability once it's up and running.
Yeah, no, thank you. Very good question. I'll pass over to Sue as well, just for the local kind of context as well. But from my perspective, good pilots and good evaluation, starting with evaluation before the pilot runs and not doing it retrospectively. So knowing exactly what you'd like to look for is very interesting because your different audiences will want different answers. We shouted as much as we could about the increase in confidence, increase in social connection, the benefit to the patient. But our government was very clear that you didn't invest until we gave them the return of investment numbers. And so I think just being conscious of what you're looking for in the evaluation in those initial pilots so that you can get further investment from local authorities as well and local support. And then a big piece will be, this is a great place, ground round, but educating clinicians will be a huge piece because many clinicians will say, this is not my job. It's the government's job to give houses. It's the government's job to create the local infrastructure. It's austerity. We do our biomedical job. We shouldn't get involved in this psychological and social element. So we've had a lot of pushback and it took us many years to change that culture. Hopefully Canada is better, but we really had an uphill battle with that.
Toby, I'd just like to say thank you for your question. Very important. We need the evidence in Canada and we need the evidence for children and youth. We don't have that even globally too much. So I'm co-principal investigator for this PHAC study. And we were successful in, as you know, getting the grant. But what was really important was the research evaluation, the methodology and the indicators. We're starting new. So then I was talking with the national office and they say, oh, you must meet Caitlin Muhl. Now, Caitlin is doing her PhD thesis on social prescribing for children and youth. And I've got goosebumps just actually being told this information because I have this jewel of a person in my hand, and we've been working together from the beginning before we even started the methodology, developing the community services. She has connections globally, nationally in UK, working very closely. So it's just been a fantastic partnership. We've got a gold standard evaluation going on. Actually, we just started the evaluations last week, Caitlin, as you know, at the hub for the follow-ups, because we started in June and the project is going to go on until next February, and we'll have hopefully the results next April, which we will be sharing far and wide, but with the local government. Provincially, we need to get our link workers in place, and actually the provincial government. I mean, we're also in quite a state of crisis. And in fact, I'm going to quote one of your medical students from the UK. I can't remember his name, but what he said,
Is it Hamad?
yes,
Hamad.
okay.
Hamad.
We need to bring back the care into healthcare, and we need to bring back the health to the healthcare system. That totally resonates. That is so foundational, what we're doing in social prescribing. We need to get the concrete evidence. When it comes to financial evidence, they're going to be very interested. But there's a moral and ethical position here for our kids. And we're talking about International UN Convention on the Rights of Child and the right to children to have a childhood and to protect their brains and development for the future generations.
That's great. I hope I'm getting this name right, and he's actually still there. Zar?
Yes, hi. Sorry, my battery was just about to go dead, so I just want to make sure I plug myself in before I lost all of you. I'm not muted. So yeah, so Robert is my first name. Just wanted to say, wow, I'm really happy I joined Grand Rounds this morning. An amazing presentation. I am relatively new to Canada, Ottawa, and CHEO. I've been working as a part-timer in the emergency department. But I'm also a co-founder of an organization called Park RX America. So Melissa Lem and Melissa is the founder of PRX. I've been at it for about 10 plus years. Most of my work was in the US. I'm actually right now doing a randomized clinical trial on nature prescriptions that's based in Washington. 6 to 16 years old. So we're doing a big study. We're in the last year right now. One of the comments that I just kind of wanted to ask about a little bit is, so there's this, push and pull I have found over the years between, having the physician do it or a clinician do it and the link worker. And I totally get that. And I think that, obviously the UK has gone with a different model, and it sounds like Canada is sort of heading in that direction. I would say Melissa and I have talked about this as well, and I've been talking about it with many other colleagues of mine. And I think one of the things you mentioned too is that it's not just about a positive patient experience, but it's about a positive provider experience. And I hate to take that away. And I think we have to, of course, balance that with the time that GPs, or in the US, for example, primary care pediatricians have in doing this, making a referral, or actually, in my case, writing a nature prescription. The barrier that's been cited most often, anecdotally and somewhat in the literature, is time. They don't have time to do it. And Bogdan, you already commented on the 10 minutes. That's about what it is in the US. And I'm imagining it's not too dissimilar in Canada, although I don't do primary care here, but did it for 20 years at a community health center in Washington. So I know time is difficult, but when I dig deeper into that feedback that I've gotten over the years, what I find is that primary care physicians and clinicians in general, they take the time to ask questions about social determinants of health. They ask about exercise, diet, etc., and they do some counseling. And one of the things that I've sort of kind of taken from this is that time can be spent in developing, in our case, Melissa and mine's case, an actual prescription rather than a referral to someone to do it. And then, there's a lot of other variables I know that you all are experts in as well, because oftentimes, the parents and families have 2 or 3 jobs each. They don't have a lot of time even to come to the visit. To spend another hour with a link worker is asking a lot as well. So there's other questions in there that I kind of want to just kind of throw out there. I wish we had 2 or 3 hours. I wish there was a much longer time span to delve in here. But I am local, and if anybody would like to talk a bit more after this, I'd be happy to dive in.
And Zar, I'm very happy to meet you. I was talking to Melissa just a couple of weeks ago because she was instrumental in getting, actually physicians now formally can go through a system through BC Parks and prescribe Museum of Nature program. So physicians actually able to prescribe within the system. So well done. I'd like to meet you certainly to having ongoing discussions about this.
That's great. Great to meet you as well. Sue, and one more follow-up question. How important is it to connect them with the right link worker? Because it strikes me that needs will be very like there's going to be some common needs, but the individuals, and you showed your word cloud, and there was a soccer stood out, but there was a lot of other specialized interests there as examples. But how important is it to find the right link worker? And do people often need to try a few until they find the right connection?
Well, just to say, Dar, we don't have link workers at the moment, so in a formal funded. So it's not a question of the right one. It's just the social worker who's there. Actually, I became, because of our social work lack at the Vanier Social Pediatric Hub, we've had some staff sustainability resource issues. I've actually become myself as a pediatrician doing the social prescriptions with the kids, and I've been using my medical students who hopefully are on the call to be assessing the community activities, and I've just been working at that ground level. So the reality is whoever's around for the way we're working at the moment, but Bogdan might like to say something again. I'm looking to you as the eagle again.
Yeah, I guess just sharing some experience from within the UK in terms of how this works. But I think the training of the social prescribing link worker, when you do a pilot, it will be crucial, because each of the link workers, their first duty is to map out local assets. So they go out, they learn which are the charities, which are the groups, and they learn those key skills of healthcare coaching and motivational interviewing. We've not really seen, I think variation happens in terms of the local demographics. So I'll give you one example. Bromley by Bow is the poorest borough in London, and 38 to 39% of the local population is Bangladeshi, and the Bangladeshi women actually who moved from abroad to London in the 90s. And the social prescribing link worker there is a Bangladeshi woman. So the local demographic matters quite significantly and quite a lot, but also the local training. However, each link worker is trained to ask, what is it that truly matters to you? And based on that, they should have the local intel and have that mapped out. After a few years in England, the maturity has gone so high that we actually have a map of all the local activities, so that a clinician could also just see what's happening in the local community on this directory. And so can the link workers. They could access a whole map of what's around. So that's an ideal world. But I think step by step with little pilots, I think it reaches that level of maturity. And actually in children and young people, we will learn from Dr. Bennett and Caitlin quite a lot actually. And we look forward to exchanging information, because as they say, this has really been an untouched area, and it's in its infancy. We've just appointed the National Children and Young People Lead across the UK at the National Academy for Social Prescribing. So we look forward to connecting them to Sue and everybody else.
That's great. Thank you. So we're a few minutes past 9:30 now. People are starting to log off. People are welcome to, I don't know if our presenters have additional time. They're welcome to stay and ask more questions, but otherwise I think we'll shut things down. So big thanks again from the CHEO community for presenting on this wonderful initiative. Much appreciated. Well done.
It was a pleasure to meet everyone, and thank you so much. And I hope next time we get to see you with us in London, maybe. If anyone visits, please let us know, and we'd love to host you and show you some social prescribing on the ground.
Thank you so much for your time, Bogdan, Caitlin. Have a wonderful day. Busy, I know you will.
Thank you all. Have a good day and good luck.